హలో
PPT?
అది ఒకసారి ఆల్రెడీ 20 days అయింది కదా. ఒకసారి ఏంటి వాళ్ళకి తీసుకెళ్ళి వాళ్ళ ఏమైంది ఎందుకు అవుతుంది అదే చెప్పకపోతే ఒకసారి న్యూరాలజిస్ట్ దగ్గర అక్కడ రూమ్ ఉంటారు కదా. ఆ, ఆ. అది ఒకసారి తీసుకెళ్ళాలంటే దానికి టెస్ట్ చేయాలి యాక్చువల్లీ. మరి వాళ్ళు ఏంటి ఎందుకు చేయలేదు అని వాళ్ళకి ఏమన్నా ఏమన్నా నాకు తెలియదు. అంటే అది వాళ్ళకి యూజువల్గా వస్తే ఇంకేమైనా ఫర్దర్ టెస్ట్ అవసరం పడుతుంది. సడన్ గా అయింది కదా, ఒకసారి చేయాల్సి వస్తుంది. ఒకసారి న్యూరాలజిస్ట్ దగ్గరికి తీసుకెళ్ళండి. కాకపోతే అంటే ఆల్రెడీ 20 days అయింది కదా, సో ఒకసారి చూపించండి. వాళ్ళు ఇంకోసారి మళ్ళీ అది రిపీట్ చేస్తారు. ఆడియో రిపీట్ చేసి చూస్తుండొచ్చు మోస్ట్లీ ఎంత ఉందని చెప్పి. న్యూరాలజిస్ట్ దగ్గర తీసుకెళ్ళండి, ఆయన చెప్తాడు కదా ఏంటి ఎవరి దగ్గర చూపించాలి, వాళ్ళే రిఫర్ చేస్తారు కదా. చూద్దాం. ఓకే, ఇక్కడికి అంత అవసరం లేదు. ఇక్కడ ఏంటి పరిచయం లేదు. మళ్ళీ చూస్తాం. మళ్ళీ అని ఏంటి కావాలంటే ఇక్కడ మళ్ళీ ఎదుర్కొని కష్టం. అక్కడ చూపుతున్నారు అయిపోతుంది. ఒకసారి చూపించాక నాకు చేయండి, నేను చూసి నేను ఫర్దర్ ఏం చేయాలి చెప్తాను. ఓకే, అంటే ఇప్పుడు సరే. అంటే అప్పటిదాకా మళ్ళీ 9 రోజులు వెయిట్ చేయడం ఎందుకు? చూపించండి కదా. ఎవరు వాడు హాస్టల్ జోలికి వెళ్ళిపోతే బయటకు పంపించుకోవడం ఏంటి? వాడుకునేది
told about so many conditions you told, maturation syncope, cough syncope. So what are they called as? Those group of syncopes are called as what? Neurocardiac syndromes.
Yes,
You know, they are because in case you are asked, even though it's not there in this case, usually fall is a very common condition, and falls with loss of consciousness also patient may not know. Very short time they fall. So it is, they are called neurocardiac syndromes because it is said that it is through the medullary receptors. So that this is mediated. Under that, as you said, you have got them vasovagal syndromes, and you have got the reflex syndromes and psychic medial, like seeing blood. Many people tell seeing blood, seeing frightening situations. So it could be vasovagal, it could be reflex, like what you told, maturation, coughs, all those things, or it can be psychic stimuli. So that is neurocardiac syndromes. Second group of syncopes are purely autonomic nervous system. You do the tilt table and all those things, no?
Yes.
Commonly tilt table test is done in the autonomic. So autonomic disorders. primary or secondary autonomic disorders. You have got a group of autonomic disorders like MSA spectrum disorders, pure autonomic failure, and autonomic failure secondary to acute conditions like demyelinating radiculoneuropathies, diabetes itself, no? So some drugs, alcohol, toxins, no? So
Yes, ma'am.
those group of syndromes is the second group. So first group is neurocardiac syndromes, under which you have got these syndromes which we discussed, vasovagal as well as reflex and psychic. And second is the autonomic disorders, various kinds of inherited and acquired autonomic disorders. Third group is cardiac. So syncope is categorized into 3 groups. Say your patient is not having syncope, your patient is not having seizure. Did he ever say any vertigo?
No,
So
ma'am.
next group will be with vertigo, without vertigo.
Without vertigo. Yes, ma'am.
Did they have any vertigo?
No, ma'am, no vertigo.
Without even sensing vertigo, sometimes these miniars can present. That is called Tumarkin's crisis. You might have heard that Tumarkin's crisis, where patient may not be in a position to tell you. Suddenly he falls down, vomits and lies down with the eyes closed and doesn't move. And you don't know at that time what happened. Is it subarachnoid hemorrhage or you will think of all conditions, but within some 1 hour or so, patient gets up normally. That is Tumarkin's crisis. That is with vertigo. And even without, not like Tumarkin's crisis, they can have vertigo and fall due to peripheral or central causes. Then you have got the next group of faults, that is, and they are postural faults. So postural faults could be due to cerebellar disease, due to extrapyramidal disease, or combination syndromes. Then you have got the lower motor neuron diseases, where you have buckling and falling due to quadriceps weakness, femoral nerve, L3 root, and then you have got orthopedic causes. So this is how you categorize them. And in senior citizens, you have got idiopathic drop attacks. You may never find the cause. They have sudden loss of postural tone, and they fall down and they get up. They have retained consciousness and they are immediate writing. So is it a drop attack? Your patient, is it a drop attack? And you have got conditions like cataplexy. A young person is a young person. So is he suffering from cataplexy? Because these are treatable conditions, no?
Yes,
So those questions will ask. So here you have a patient who is fully conscious, suddenly falls down with multiple injuries, and he gets up on its own with not much problems at that point of time.
yes, ma'am.
So without loss of consciousness, sudden falls and no other clue. A very young person, first I would definitely consider cataplexies. No? Disorders like cataplexy. So what will be the questions you will ask if it is cataplexy? It is easy to treat. No?
Yes, ma'am.
What other symptoms you will elicit to know? Before we conclude, it is a fall due to pedunculopontine complex. No? At that time, we have seen him 1.5 years back when he was only falling. No? So is it a cataplexy? So what are all the questions you will ask?
Cataplexy patients will have this collapsing falls, like loss of tone will be there, sudden
Yes.
fall will be there, and
So they have
essential-
sudden falls. As you typically said, they collapse like a bag of bones. Just like that, like a bag of bones, they collapse. They do not lose consciousness. They get up. But most of these patients also have hypnagogic hallucinations, narcolepsy, and sleep paralysis.
Yes.
It's all these come together. The narcolepsy, they will not tell. Because in the classroom or during some active conversation, they slip off and they don't know it is part of the syndrome. And to reveal that may be a stigma. So they may never tell that. So you have to elicit that symptom. Similarly, hallucination and sleep paralysis will be considered as psychogenic. A sleep onset hallucinations And sleep paralysis also, patient feels very frightened that is paralyzed. But when someone comes and touches, he will immediately become all right. So naturally, people will think these are not organic situations. So they will not reveal. So you have to ask whether any of these things are, otherwise you will invariably miss these cases. So that is cataplexy. That's very much possible. Second, whether it is a young onset drop attack. Usually, idiopathic drop attacks are common in elderly, and even another cause for drop attack is top of the basilar syndrome, Kaplan syndrome, where the peduncular branches of the top of the basilar artery is suffering from hypoperfusion. So then initially other features may be not there. After 2-3 falls, he will go into full-fledged vertebrobasilar stroke. So that peduncular branches of the top of the basilar artery getting occluded will just produce drop attacks. But usually they are elderly. And idiopathic drop attacks is by exclusion. You investigate and you don't find anything. That is called idiopathic drop attack. So sudden loss of postural tone with immediate writing and retained consciousness. And the cataplexy. These are DDs for these patients' falls. Then how are the patients with the extrapyramidal disease fall? How are the patients with autonomic dysfunction fall? How are the patients with cerebellar disease fall? These are the other group of conditions in the neuroaxis. No? So cerebellar patients, how do they fall?
Cerebellar patients usually falls to sidewards, ma'am. Swaying
Yes.
and reeling type of fall can be there. And in case of extrapyramidal, this
So they reel and fall.
reel and
You have
fall.
typically seen alcoholic patients who reel in a very wide arc, fall somewhere and come with subdural hematomas. You see? So cerebellar falls, gentle swaying in the anterior lobe of the cerebellum, they do not generally fall. Unless they are very careless and they put their legs talking to someone. The other part of the neuraxis, they do not fall. On other parts of the cerebellum, they do not fall. The flocculonodular lobe and its connection to the vestigial nucleus and the vestibular structures. So that there they fall very obviously. It will be just like a drunken gait, long route. They go through a long way swaying. They reel, it is called reeling, and then they fall. That is cerebellar fall. Rest of the cerebellar system, they do not fall. Inferior cerebellar peduncle and flocculonodular lobe, they can fall. Then you come to the autonomic faults. How do they fall? Autonomic? Supposing this person is getting an MSA or some kind of autonomic dysfunction due to acquired or inherited cause, what will be the history like?
The patient
They
will
do not fall suddenly. They will have warning features. It always happens in the standing position. Autonomic postural hypotension syndromes, they do not fall in the other posture. So they always fall in the standing posture. So that is one point to differentiate cardioembolic disorders where presyncope happens. That can happen in a lying position also. And strokes, mimics, strokes, they all can happen in any position, whereas autonomic, always in the standing position. Second, they get pre-syncope-like features, graying of vision. They will feel that blurring of vision is coming and they feel an ache in the neck or shoulder because of the hypoperfusion to the upper body. So always in the standing position, preceding graying of vision and aching pain in the neck and upper body due to hypoperfusion. Following that, they slowly sink down. Unless it is severe autonomic failure where sudden orthostatic fall happens, usually with the drugs. Otherwise, the degenerative diseases, they give them time. So these points, if that is present, it will help you to consider an autonomic. And other features like sweating abnormalities may or may not be there. So that is autonomic first. Then we will come to basal ganglia. No? In basal ganglia disorders, what are all the idiopathic Parkinsonism, atypical Parkinsonisms? No? How do patients fall? That is what, that's correct. How do they fall?
Idiopathic
In
Parkinson's disease
idiopathic
patients may
Parkinsonism.
fall forwards, ma'am. In case of atypical Parkinson's, like MSA, they may fall sidewards, and PSP they will have toppling type of falls. They will fall like log of wood backwards. They will fall. And
So
in
as you
case of-
said clearly, in primary Parkinsonism, actually falls are less common, but it will appear that they are going to fall. It is in the anterior posterior plane. They can fall both forwards and backwards. This is due to propulsion and retropulsion. So they will keep running forwards or backwards, and you will feel that they are falling, but usually they manage themselves. Idiopathic PD is in the anterior posterior falls. It is due to the propulsion or retropulsion, and the falls are less common than the feeling of falls. That is idiopathic Parkinsonism. So that is why this pulsion is described by James Parkinson as running. No? They run and they try to fall. So you know the definition of Parkinsonism by James Parkinson? How did he define? Just for historical interest. Involuntary tremulous motion in parts, not in action. That is how he described the resting tremor. Involuntary tremulous motion in parts, not in action, with the propensity to shift from walking to running. That is a propulsion and retropulsion. Walking is difficult, but running is easy because of the pulsion. And mind and intellect remaining unaltered. So that is the definition by James Parkinson. Involuntary tremulous motion in parts not in action, with the propensity to run from walking to running, mind and intellect remaining unaltered. Hello? என்னடா? ஆமா, இன்ஸ்டண்டா எல்லாரும் சாப்பிட்டுட்டாங்க. வேற சுடல். அம்மா கிளாஸ்ல இருக்கேன். கிளாஸ் 7 மணி கிளாஸ். 7 மணிக்கு அம்மா கிளாஸ் இல்ல. ஆமா, கிளாஸ்ல இருக்கேன்டா. That is James Parkinson's definition. So that is idiopathic Parkinson's. Other atypical Parkinsonism, what are all the conditions you have under atypical Parkinsonism?
one is multi-system, multiple MSA, CBS, PSP, and DLBD.
So what are the conditions where false is the presenting feature?
In case
You
of
know that, I am sure. No?
PSP.
Yes. So the disease starts in the brainstem. The
Yes.
disease does not start in the basal ganglia. It starts in the brainstem. Pedangula-Pandian complex, as you have written. And typically it is a pivotal falls. They fall like a pillar falling back. It can be in any direction, not necessarily backwards or sidewards. It can be in any direction. They just fall. They don't know what happened. They are unable to describe. Many times they might mistake somebody who stood near them, pushed them or something like that in the early period and late. And at that time when you examine also, you may not have much features. So it's an exclusion diagnosis as a beginning of a grievous disease. So that is PSP falls. MSA falls is usually autonomic plus or minus basal ganglia and cerebellum, whichever type of MSA it is. So usually the falls in MSAs are due to autonomic and the characters will be there. So this for this fall at that time, if he has come to us, we will consider cataplexy, drop attacks, and brainstem syndromes, brainstem extrapyramidal syndromes. So these are the differential diagnosis. You will keep that in mind. Next, this patient develops slowness. No?
Yes, ma'am.
So you analyze that symptom. We have told many activities.
Yes,
So you analyze that symptom.
So slowness of activities of the daily living. First, initially, it was started from the lower limbs, madam, unable to walk, and after that, patient is having this slowness in the other activities with the upper limbs as well as in his daily activities. So mostly whether the slowness can be either mental slowing or the motor slowing. Mental slowing usually can be due to this depression, and some psychiatric disorders can have any execution deficits can have this mental slowing. And the slowness, whether it is started with the upper limbs or the lower limbs. If it is started with the lower limbs in the substantia nigra, the medial portion is representing the upper limbs. So if it is starting with the lower limbs means, then mostly the idiopathic Parkinson's disease can be ruled out in the initial the initial onset is
So
from the
lower limb
lower limbs.
onset extrapyramidal syndrome is generally not due to idiopathic PD. That's a very key point. Very
Yes,
good.
ma'am. Yes, ma'am.
Mm.
And it can be and the lower limb, whether it can be any atypical Parkinson's or it can be any cortical pathologies like NPH or any vascular disorders or any Binswanger's disease like that.
So good. So you are told you think he is slow because his walking speed reduced.
Yes, ma'am.
So you call it as a fixed distance walking time. Usually they lag behind their fellow walkers and they decline, they do not suffer from any breathing problem or chest pain which are other causes. So lag behind for which they are not able to give an explanation. As you clearly told, dysexecutive syndromes also can manifest with slowness, but there it is voluntary. Whereas this, in spite of effort to keep pace with their fellow walkers, they are unable to do that. So that is called fixed distance walking time is reduced, not because it is due to a lack of initiative. Patient is unable to do the speed. So that is called bradykinesia. No?
Yes, ma'am.
So your second symptom is bradykinesia. When do you call it as hypokinesia? Usually both go together. Bradykinesia and hypokinesia go
Bradykinesia
together.
is decreased speed, velocity, and hypokinesia is due to decreased amplitude.
Yes. So how much he is clearing the feet from the floor, the height becomes very much less compared to his premorbid walking. That is hypokinesia. Usually they go together. So of course we have to see patients, family may not be able to tell. So there is a second symptom is bradykinesia. So which part of the neuraxis you would like to put?
Bradykinesia can be due to this basal ganglia and its connections, like mostly this.
What are all the basal ganglia circuits? And
This direct pathway, indirect pathway, and hyperdirect pathway. These three are main, ma'am. Direct pathway is due to this cortico, striato, pallido, thalamo-cortical. In this, the pallidum is GPI. Indirect pathway is cortico, striato, pallido, pallido, GPE followed by GPI and thalamo-cortical.
Subthalamic.
Subthalamic.
So after the globus pallidus externa, you have got the subthalamic.
Then GPA and then cortical. Hyperdirect pathway is cortico, subthalamo-cortical.
Cortico, subthalamo-cortical.
Cortical. And
then
another two pathways are
striatonigral and nigrostriatal.
striatonigral,
And then you got substantia nigra to pedunculopontine. These are the 5 major circuits, of which commonly discussed are the first 3 circuits, as you told. But in our patient, already the 5th circuit is deranged. Yes, that's the first symptom. And second, it is probably the direct pathway. So slowness. So that is what we are getting from the history. Second structure is directly going to the basal ganglia, probably direct pathway. Yes. Then next you told speech disturbance.
Actually, this speech disturbances, the space slides. 1 minute, slides are not.
Is it typically what kind of speech we expect in this patient? We expect a monotonous, unmodulated progress, and he is already having bradykinesia. So when he starts, it will be monotonous, unmodulated speech with a progressive decrease in the voice volume. Yes, as a manifestation of bradykinesia.
Yes, ma'am.
So it will be a monotonous speech. Really, the dysarthric component manifests only not with the dysarthria, but monotony and progressive decrease in the voice volume. Did he have any other cause? So if it is part of the extrapyramidal syndrome, we expect monotonous speech with progressive decrease in the voice volume as conversation is going on.
Yes, ma'am.
What was, okay, in the examination, maybe you will tell.
Yes, ma'am. Yes, ma'am.
Speech abnormality is there. Was it monotonous or what? We will analyze in the examination. So if any other part of the neuraxis is getting involved, now we found 2 loops are involved. If any other part of the neuraxis is involved, the speech will be altered accordingly based on whichever structure is involved. If it is only due to part of the bradykinesia, it will be monotonous with progressive decrease in the voice volume. So that is the third symptom. Characterization will happen with the examination.
Yes, ma'am.
Behavioral changes, no?
Yes, ma'am.
So he is angry. You told any other behavioral change? Only angry, yeah?
Only angry, ma'am. That too not that much significant. On repeatedly asking about this behavior and forgetfulness, they told from the last 4 months, ma'am.
So is it reactive? You said he has become abusive.
Yes, ma'am. Yes, ma'am.
Abusive means he uses wrong words, huh?
Yes, ma'am. Yes, ma'am. Like bad words and all. Previously is not that much. Only sometimes he used to be abusive, but now most of the times for small things and repeatedly asking something, whether like if they are not telling the things, then again he is, why you are not telling me, like that. He is sometimes abusive. Not that much significance is not there, but compared to the previous premorbid
So that
condition.
is what we define as a personality, you see. Because personality is very, very wide spectrum. Huge number of personalities are there. So it is considered abnormal if it is changed from the premorbid state. Each one of us are different. So if you change from what you are premorbidly, it could indicate abnormality. But we define a personality as abnormal if it is harmful to self or environment. That is the definition. Normally, wide number of personalities are there. So you don't call them abnormal. They are called abnormal if they are harmful to self or environment. Then it becomes an abnormal personality. But altered personality, that indicates disease. So premorbidly very docile person becoming aggressive or aggressive person becoming docile, all indicate altered personality. And as you have clearly written, usually personality is a function of the frontal lobe. So whether this person is after picking up brainstem, basal ganglia, is it going to the frontal lobe is a question, no?
Yes, ma'am.
So what are all the frontal lobe circuits? That's possible. There is a change in the personality, definitely.
Yes,
She's
ma'am.
telling. So after that, we'll discuss what are all the situations where aggression happens. So what are all the frontal lobe circuits?
Frontal lobe, this dorsolateral prefrontal cortex, orbitofrontal cortex, and medial prefrontal cortex, and frontal subcortical circuits.
So we have like just like basal ganglia circuits.
Yes,
We
ma'am.
have some frontal lobe circuits, no? What do you call them? They are named circuits. No? Motor circuit. You see? Motor circuit is corticopontocerebellar, all these pathways getting involved from the motor cortex.
Yes, ma'am.
So motor cortex, it starts and goes through the pallidothalamo-cortical outflow. So motor starting from the primary motor area and going through the pallidothalamo-cortical outflow is the motor circuit. Second is the oculomotor circuit. That starts from the eye field and then traverses through the pallidothalamo-cortical outflow. So starting from the motor area is motor circuit, oculomotor area and the pallidothalamo-cortical outflow is the oculomotor circuit. Third circuit is dorsolateral prefrontal circuit. So motor circuit, oculomotor circuit, dorsolateral prefrontal circuit is starts from the dorsolateral prefrontal cortex and goes through the pallidothalamo-cortical outflow. Then fourth circuit is the cingulate circuit. So motor circuit is motor activity. Oculomotor circuit is eye movements. Then dorsolateral prefrontal circuit is executive function. And cingulate circuit is obsessions. And medial orbitofrontal circuit is disinhibited behavior. All these go through the pallidothalamo-cortical outflow. So motor circuit, oculomotor circuit, dorsolateral prefrontal circuit, cingulate circuit, and medial orbitofrontal circuit. They are all linked to the basal ganglia. They start in the area which goes by the name of the circuit and goes out through the pallidothalamo-cortical outflow. So in this case, because he was cingulate range, which all parts? So if you call this as a, because you said that his anger is only mild, it is not very severe. It's not very frightening to the family members. So a very mild one means it may be a personality change, which you rightly pointed out could be due to a dorsolateral prefrontal cortex circuit going through the pallidothalamo-cortical pathway may be going. So you'll call it as a third frontal circuit. So it is the pedunculopontine oscillator complex, the fifth brainstem circuit, then first basal ganglia circuit, the direct pathway, and third is the third frontal
LPFs.
basal ganglia circuit. Supposing the patient is very aggressive, really frightening, no?
Yes, ma'am.
Then what circuit you would like to put in the frontal lobe?
Cingulate.
Yes, cingulate circuit. So cingulate patients are very, very aggressive, much more aggressive. They are physically aggressive, abusive, and they have, in addition, they have got obsessions and they may sometimes be mute. Their communication may be very poor because of the cingulate mute, and they can be very destructive and aggressive, and they can have obsessions. Only this way it should be done. Mild change also, they become aggressive. Any other area where you have aggression, cingulate area, otherwise?
Amygdala, other.
Amygdala, then, and intercollicular areas. Brainstem, intercollicular, shamrage, lot of shamrage, no? So amygdala is one condition where you get aggression, which is usually seen in patients with major mental illnesses. So amygdala involvement can lead to mental illness where aggression is a prime part. And intercollicular section is sham rage. That is rage against themselves and others. So they may even do self-harm. So intercollicular sections, the functional intercollicular section happens in what condition? Lesch-Nyhan syndrome. Lesch-Nyhan syndrome. Not in this age group, much younger. So hypoxanthine guanine phosphoribosyltransferase transferase enzyme deficiency, where hypoxanthine and guanine is not getting converted into xanthine. So because of that, this hypoxanthine and xanthine becomes converted into uric acid in the peripheral circulation. That results in severe arthritis. So these Lesch-Nyhan syndrome patients have arthritis due to uric acid accumulation from hypoxanthine and xanthine getting converted to uric acid in the periphery. And in the center, the xanthine oxidase is not there. So deficiency of hypoxanthine and xanthine and the products of hypoxanthine metabolism is absent. So this results in a functional intercollicular section that results in sham rage, severe rage. So that is Lesch-Nyhan syndrome, hypoxanthine guanine phosphoribosyltransferase deficiency. So these are other locations where aggression, but this is very mild aggression. We can leave it off. It can even be not due to brain involvement. It can be a reactive depression. Agitated depression. I'm sure you heard of the term. All depressed people are not docile. There is a condition called agitated depression. When they are depressed, they are angry. So that is called agitated depression. So it can be a reactive depression also to be considered, for which we will ask the patient Is he expressing sad ideas? That why at this age, nobody in my family got this disease. Why I alone got this? I don't want to live, don't talk to me. No? That kind of vegetative symptoms. Poor sleep, poor appetite, and expression of grief. If it is there, it could be part of an agitated depression. Or it may indicate that frontal lobe is getting involved. And then you get forgetfulness for recent events. So he was difficult remembering where he placed certain stuff, where he placed certain objects. Okay. So what do you think it could be? Is he placing always? I tell that when they put where they placed objects, are they objects which have got a place to be kept?
Visuospatial or frontal?
So if they have a visuospatial problem, objects which have a place to be kept, they will place in the wrong place. You see, if it can be visuospatial, in which case it becomes a parietal lobe disorder.
Yes.
So if it's a visuospatial problem, so you will always ask that question. Is it with reference to objects like puja material, which will not be keeping in the kitchen? Or kitchen material, you are not going to put it in the puja room. So is it this kind of objects?
No, ma'am. Like normal place where he used to keep, though in that place only he will forget.
Then it could be memory. You ask in testing itself, you hide 5 objects and show where you are hiding, and then patient has to retrieve. That is a test of recent memory.
Yes, ma'am.
Hiding 5 objects and in front of the patient, telling him and tell him to correctly pick the right object is a test of memory. So there you place it in the place where it should be kept only, but forget and then ask, then it becomes a memory problem. So, so that is more consistently happening. Yeah?
No, ma'am.
All
Not.
of us, it happens occasionally. No?
Yes, ma'am. Due to attention problem, also can it happen?
Now, is he really having that problem? That's what I am asking.
He is
Could be due
having
to anything.
repeatedly asking. They told these 2 complaints on taking the history. They have told these symptoms, ma'am, but not that much severe. Only occasionally he forgets, and for that objects also he will sometimes abuse his wife.
If he is abusing his wife, saying that, then it must be happening in the pathological level. Normally, when it happens to all of us, I am sure that when you
Yes,
are
ma'am.
preparing for your exam and you are in a hurry to finish a topic, you may throw your key somewhere and then forget. That is a poor attention, and it is not even a gross attentional pathological attention disorder. No. Whereas if he is forgetting and fighting with a wife, that is amounts to pathological state. So most probably it is a recent memory problem, I am thinking, because if it is due to poor attention, it is like an absent-minded nature. So next time he can correct it or edit it. If that is not happening, probably it is, if yes, it is attention, it becomes frontal lobe or psychological.
Yes,
Or if it is recent memory, it becomes temporal lobe.
ma'am.
Or if it is visuospatial, it becomes parietal lobe.
Correct.
So you have to get the correct information to know which other structure is involved. Is it frontal lobe or is it a temporal lobe or parietal lobe? So that depends on hair splitting this particular symptom to know what really is happening. So I feel that it is recent memory because he is consistently doing it and blaming somebody else. That usually happens with recent memory problem. So from it started in the brainstem and over 1.5 years, it just grow slowly ascended up the brainstem and gone up to the cortex. What was his work?
Security guard, ma'am. In a mall, he is a security guard. He usually this duties and duty working time he should sign, as well as some work, what are the work pendings he should tell to the other person who comes on next to him for the duty. So those things sometimes he will miss the entries and he will not place and he will not tell the proper things to the next member regarding those things.
What that will come under?
Execution.
Working memory.
Working memory.
It's
Okay.
working memory because when he has a work shift, he has to convey that information. but he doesn't have to convey that information to a permanent memory. It is a information manipulation for functioning at that point of time. So that is working memory. So that belongs to the frontal lobe. So he's having working memory problem. So he doesn't give charge to the next person in the proper way. So, okay, next, what else?
That's all, ma'am.
So at this point, as you told, so many structures are involved. And you have clearly told the possible condition is degenerative. Why do you think degenerative? It is so slowly progressive.
Yes, ma'am.
So grossly, we consider neurological disorders as short duration, progressive or regressive, long duration progressive or static, and intermittent conditions. So long duration progressive conditions come under degenerations, slow viruses, and slow growing tumors. Whereas long duration static or fixed insult, like you had an encephalitis with sequelae, or you had a head injury with sequelae, or congenital agenesis of various parts, the symptom will be there from birth. So long duration static syndromes are there, long duration progressive syndromes are there. So under progression, you have got degeneration, low-grade tumors, and low-grade slow viruses. So this is apparently 2 years, so it is not a short duration.
Yes, ma'am.
So whether you are dealing with a degenerative disease,
Yes, ma'am.
vascular Parkinsonism, you considered why? Because the points for or
48,
lower body.
yes, ma'am.
Lower body.
Lower body involvement it is there, so I consider. And second thing is that against features are there is no risk factors like diabetes or hypertension is not there, ma'am. And second
And how
thing,
often a vascular Binswanger syndrome presents with repeated falls, which are so frequent in your patient? No, very frequent falls. It's not at all a feature.
yes, ma'am.
So I'll not put vascular as the first
First,
possibility. No,
treatable causes normally
yeah.
I kept.
No, that is okay. Treatable cause you should definitely consider. Considering the young age of the patient, the quality of life is going to be very much affected. You don't want to give a degenerative disease. Agreed.
Yes.
But you can consider vascular Parkinsonism in areas. Investigating points for being frontal lobe involvement and lower body onset.
Yes, ma'am.
But falls as the presenting feature is very,
Against
very, very uncommon. So that is less likely. You think of that and you'll exclude.
Yes, ma'am. And
Vascular
autoimmune.
PSP, of course, you can consider. So he's not having any vascular risk factors.
Risk factors
So
are
without vascular risk factors, can vascular PSP or any vascular syndromes occur? They do, no?
yes, ma'am. Hello, ma'am.
Purely CNS vasculopathies are there. He's a young person. Purely CNS vasculopathic syndromes are there. They need not involve the systemic body parts, or they need not involve the peripheral nerves. They may be purely CNS. But the clues in the history will be headache, because it involves the leptomeninges. So they will have headache. Then they will have cognitive decline as the first feature. And headache and cognitive decline as the early feature are not false. So whether it is a primarily vascular Parkinsonism due to vascular.
Hello, ma'am. Hello.
And his cognitive decline came very late. No? So that also is less in the lower in the list. Then autoimmune, that is possible. You are considering autoimmune for what reason? Again, it's a young onset.
Yes, ma'am.
And relatively rapidly progressive, you can call it if you want. No.
Yes, ma'am.
So that is a possibility you can consider, considering the age. paraneoplastic etiology, we consider most of the disease. Otherwise, the classical paraneoplastic syndromes in the neuraxis, what are they? Classically in the upper motor neuron, which all structures get involved commonly in paraneoplastic. Paraneoplastic extrapyramidal is there, but it is very, very less common.
Yes, paraneoplastic brainstem is common.
Yes, you can have brainstem syndromes,
And
then cerebellum.
cerebellar.
So it is brainstem and cerebellum. Usually, paraneoplastic syndromes in the upper motor neuron involve the brainstem and the cerebellum. They are the commonly involved structures, and they can involve the retina, optic nerves. No?
Yes, ma'am.
So retinopathies, optic neuropathy, brainstem, cerebellum. You can consider. You can even proceed 1 to 2 years, and we have seen paraneoplastic PSP syndromes.
Yes, ma'am.
I have published in this, I think it is in the Annals of Indian Academy of Neurology, one of the reversible dementia syndromes. Under that, you have published that. But that person had a secondary angiosarcomatous deposit in the scalp 2 years later. Every time he was investigated thoroughly, but we did not find it. And 2 years later, he presented with a swelling in the head. That turned out to be angiosarcomatous deposit of unknown location. So PSP as a paraneoplastic syndrome is common, but the clues will be, usually they are very rapid to progress, and they have some asymmetrical features like a unilateral vocal cord paralysis, something like that. If it is there, it's a clue. Some asymmetrical features. Neuroinfections. What neuroinfection is in your mind? Which starts with the faults?
Like not with the predominant falls, ma'am. The slowness and falls and this some behavioral disturbances. And this age group. One is this like PSP mimicker like this Whipple's disease and neurosyphilis and this prion diseases. Whipple's, neurosyphilis, and prion, ma'am. And GSS usually presents with predominantly
Neurosyphilis,
ataxia.
usually you have got a parenchymatous syphilis, meningavascular syphilis. No?
Yes, ma'am.
Meningavascular will be meningeal features and focal signs. Whereas GPI is more of cognitive. And very late into the disease, you can have extrapyramidal. Mainly it is a frontal lobe syndrome with the grandiose ideas and general paralysis of the insane, neuropsychiatric. Their symptoms are significant neuropsychiatric. And your patient is not having significant neuropsychiatry.
Yes,
Very
ma'am.
mild neuropsychiatry, you only told.
Yes,
So I don't know whether that will be considered. What prion disease in your mind when with this type of phenotype?
Usually that is due to ataxia with fall. Predominantly this GSS can have, but
What is the typical manifestation of GSS?
ataxia,
Ataxia, severe myoclonus,
severe
and
mild.
rapid dementia. Rapid severe dementia. Prion disease and all, you can tell very last only. No? I will, my order will be young onset neurodegenerative syndrome is still a possibility. Only point is the age is young. And second, of course, I will consider a rare possibility of an autoimmune. Others became very low in the list.
Maybe metabolic conditions, whether we should
Prion
consider
disease,
them.
Jesman-Straussler is cerebellar plus severe myoclonus and severe dementia. That is Jesman-Straussler. Whereas CJD is corticostriatopallidospinal syndrome. So it starts in the cortex. It doesn't start in the brainstem. Your patient started in the brainstem. So
Brainstem.
prion disease, CJD, Jesman-Straussler, and you have got familial fatal insomnia syndromes, variant forms of CJD. None of them start with the faults and the way it, basal ganglia can be involved, cortex can be involved. That way you can say, but your patient's history is very clear. It is not the way CJDs or Jesman-Straussler or familial fatal insomnia present. So I think I will not consider prion disease which are known to us.
Yes,
You may have an unknown prion disease. Yes, anything can happen in medicine. So that will, but neurosyphilis also generally it is either meningovascular syphilis or parenchymatous syphilis, and both of them, so many points are odd.
Yes.
But it is good you considered them. PS is a young man. You will investigate thoroughly for all these things, but I feel it will be less likely only. Young onset degenerative PSP still appears first possibility to me. And second, I will consider autoimmune because it can mimic anything.
Yes.
Okay. On examination, what did you find?
Examination, positive findings, ma'am. There is positive findings I will tell. Pulse rate, BP, no pallor icterus, sinuses clubbing edema, no lymphadenopathy. His smoker is 22/30 and he is a right-handed person, ma'am. And this speech. राजा राजगोपालचारी କୁହନ୍ତୁ ଜାନୁଆରୀ ଫେବୃଆରୀ ମାର୍ଚ୍ଚ ମାସ କୁହନ୍ତୁ
What do you feel his speech is?
ଠିକ ସେ କୁହନ୍ତୁ growling
No
type.
voice volume and monotonous.
Yes.
It is
Actually,
clearly
sometimes.
monotonous speech.
Okay.
There is no undulation at all, no?
Okay.
But progressive decrease in the voice volume is there or not? You have to listen to his talk for some more time.
Yes. Yes.
So I feel it is a monotonous speech. What is growling speech? I have not heard of this term. What is that growling, ma?
I can.
Growling means what?
Like
I have
patient.
not heard of this term actually.
Uh,
When do you use the term growling?
patient will have this fluency will be impaired and the patient will be having like explosive type of speech, but that is not considered to be a spastic dysarthria.
See, explosive speech you get in what condition?
Explosive speech will get in cerebellum, ma'am. Sorry. Straining quality of speech.
Straining quality is spastic.
Spastic.
But here that is called growling speech. Huh?
Like in PSP, due to this.
So is the term used in the textbook? Yes, I have not heard of this. That's why I have not read also. You read it from which book, ma'am?
I forgot now. Once I will see and I will keep the reference.
Okay. Anyway, I am not aware. So whether you can use that those terms, if it is there in some text, and you should remember the reference because they might ask. Now for this, nobody will fail or anything. But I have never heard of this term. So if it is there in some literature, you can definitely use it. But you should describe that my patient is not having any spastic quality. He is not having any explosive quality, which you are telling is part of the growing speech. I don't think so. It is a monotonous. Just listen once more. There are no prosody at all. It is a monotonous voice volume.
ठीक से कुहंतो
It's a monotonous speech, it's a typical monotonous speech. Okay.
And language, this spontaneous speech, some non-fluency is there. Apart from that, everything is normal, ma'am. And mocha is 22/30. Trial B is impaired. I will show the figure. And forward test, tap test is also serial subtraction is unable to do. And total is 22/30. Fab score 12/18. Lexical fluency is 1/3. Motor luria test 3 correct consecutive series. With the examiner, he did that one. Conflicting instructions, there are 2 errors, and go test also 2 errors are there. This is I'm doing this stage palm test, ma'am. With me, he able to do. After that, I told him you do yourself, but he is unable to do in the sequence. Like 2 times he is hitting with the fist and 1 time with the palm like that. So errors are there, ma'am. He is unable to perform this motor area. And this go no go test. I told go no go test. Tap 1 time. If I tap 1 time, means if I tap 2 times, you don't tap. So out of that, there is some sequence of 8 to 9 sequences. In that 8 to 9 sequences, he did 2 errors.
Okay.
So this is the summary of that, and attention trial A, trial B impaired with this go-no-go test and conflicting instructions and mortalluria, and response inhibition. These anti-saccades are impaired. I will show in the ocular examination. Parietal lobe is normal, and only this complex verbal written calculations he cannot do. And second thing is with parietal, he is able to with pantomimes that transitive, intransitive is able to do, and imitation he is unable to do that imitation with his left hand. He is able to do those imitations with right hand. This salute, namaskar, and this University of Texas sign he is unable to do with this left hand, ma'am. And that namaskar he is able to do like both the hands. Combining, but this I will show you that video, ma'am. Here I am asking to flex his second and third finger and extend his first and fourth finger. With right hand he is able to do that one, but with his left hand he is unable to do. So whether this is
Otherwise, is he having good power in the left hand?
yes, ma'am. Power is normal. Hand grip is 5/5. The hand grip is normal, ma'am.
Okay.
So whether to keep this in the either limb kinetic apraxia or
The
callosal
mild type of left arm apraxia is there.
yes, ma'am.
That usually happens in anterior callosum involvement.
Yes, ma'am. Callosal
So whether there is some
non-dominant hand it is involving.
yes, that is what gets involved usually.
Yes, ma'am.
So whether he has got a anterior corpus callosum and his connection getting involved is usually the cause for that. Because the frontal lobe is there and the
Yes.
white matter tract in that location may be getting involved, possible.
Yes.
Okay. Then
This is the trial B test, ma'am, and errors are there. Trial A test, graphic luria test, parietal lobe. There is no hemineglect. There is no simultognosia. Clock drawing is able to draw, and there is no distortions while drawing the circle, and numbering also. There is no perseveration or no response inhibition. Occipital lobe is able to identify, and there is no visual object agnosia, and there is no color vision, color naming, color pointing, matching is able to do. Primitive reflexes, only palmomental reflex bilateral present, snout, rooting, grasp, glabellar tap are absent. Cranial nerves are normal, ma'am. Coming to the extraocular, 346 cranial nerves, extraocular movements, mild vertical gaze palsy is there, down gaze, and horizontal jerky pursuits are there, ma'am. And hypometric saccades, both horizontal and vertical, but vertical are predominantly affected. Hypometric saccades are there. So here I am checking.
told Whipple's disease, no? Told infection under that.
Yes, Whipple's I told in view of this PSP, like this predominant brainstem involvement is there and slowness is there, and with some plus minus this frontal lobe disturbances in the form of behavioral it is there, but there is no constipation or there is no abdominal pain and there is no diarrhea. But sometimes
What is the eye sign typically described in Whipple's disease? You see, Whipple's can present with a wide spectrum of clinical features.
Yes, ma'am. Yes,
It can present just like meningitis, it can present like dementia, it can present with Parkinsonism, it can be ataxia, it can be a combination of all this with the GIT symptoms.
yes.
Agreed, rapidly progressive, but that and all I agree. Those points you told. What it doesn't start in the way this patient started because you're showing eye signs.
Yes.
What is the typical eye sign in?
People usually have this vertical upgaze palsy, ma'am.
Yes.
And this vertical upgaze palsy and the square wave jacks also can be there, and this hypometric slow saccades can be there.
If you do a computer analysis of the eye movement,
yes,
it's the oblique saccades. Clinically, very difficult for us to look for oblique saccades. You cannot do that. So you do a computer-based analysis of eye movement. It is not horizontal, it is not vertical. It is the oblique saccades. Anti-saccades you mentioned. Anti-saccades get involved early in what condition?
Anti-saccades is due to this PSP, ma'am. And that is due to the involvement of
Anti-saccades involvement as a early feature is typically described in frontotemporal dementias. So anti-saccade, early anti-saccade, at the end everything will go and everything. So early impairment of anti-saccades is a feature of FTD. Whereas oblique saccades is Whipple's disease. In addition, you have got oculomasticatory myarrhythmia. So in the eye in Whipple's disease is very, very characteristic. That movement disorder itself is diagnostic. One is do a computer-based analysis of eye movement and demonstrate oblique saccade impairment. Second, you will demonstrate the masticatory movement synchronously going along with the convergence, divergence, and vertical rotary movement of the eyes. So convergence, divergence, and also vertical eye movement clubbed with the masticatory movement. That is oculomasticatory myarrhythmia. So these two features, oblique saccades, clinically they cannot demonstrate by computer analysis, and oculomasticatory myarrhythmia. That is a convergence, divergence, and also oblique and vertical eye movement, which are spontaneous and synchronous with the masticatory movement. That is very diagnostic. So this person
मध्य
the
देखो
vertical
कैमरा देखो कैमरा
due
देखो
to-
पेन देखो कैमरा पेन पेन
Agreed.
कैमरा
Yes, ma'am.
The eye
Pen
movements
dekho.
appear very slow and
Pen dekho.
hypometric.
Yes, ma'am.
पेन देखो मौसा पेन देखो पेन
I'm
देखो
checking for the pursuit, ma'am.
पेन देखो पेन देखो पेन देखो
Broken pursuits are there, in between
Pen dekho.
jerky pursuits are there.
पेन देखो पेन देखो
Down
Dekho.
gaze, mild restriction is there.
Dekho, pen
Vertical
dekho.
up gaze also. Up gaze is normal, but
पेन देखो
down gaze, mild restriction is there.
Yes.
पेन देखो
So trigeminal nerve, facial, rest of the cranial nerves are normal. Bulk is normal. Tone, there is neck rigidity is grade 3, ma'am, and upper limb, lower limb, grade 2 rigidity is there. Power is normal, 5/5. Reflexes are 2+ and plantar is bilateral mute. Cerebellar, there is mild
pen chuko.
dysmetria
हाँ ना कुछ हुआ
in the
जोर से
left
करो।
upper
हाँ।
limb.
हाँ करो हाँ करो हाँ सेहत करो हाँ टिप रे करो हाँ टिप 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 हाँ हाँ करो करो हाँ करो
This is not cerebellar, ma'am.
Yes.
Cerebellar is proximal, no?
Okay.
Here, after reaching the tip of the nose, he is having some small shaking like. Whereas cerebellar is proximal, it's not a distal clumsiness. So this you can call it as a distal clumsiness. It is usually multifactorial.
Sensory examination is normal. Movement disorders, frontalis overactivity is there, and bradykinesia, finger tapping, pronation, supination, opening and closing of hands, grade 1 is there, and toe tapping, leg agility, grade 2 in the lower limbs is there. And this patient he gets up with support of the chair and his erect posture, wide base is there. There is no difficulty in initiation of the gait, and there is a lower limb lower limb grade 2 mild intermittent dystonia is there. Along with this arm decreased arm swing, and there is arm levitation, and there is dystonia of the left upper limb as well as the left lower limb grade 2.
Agreed. He has a straightal toe and he is having dystonic posturing of the left hand and a broad base. So gait is broad base. Will you play that once again? That video.
असंतो बोलो जाओ
This arm
There is
position.
a broad-based striatal toe, dystonic posture of the left hand. Usually levitation, the hands goes up. Here it is something like a dystonic posturing. Rather, levitation, they move the hand up. This looks like a dystonic posture, straight toe. Agreed.
Plus sign is negative, ma'am, and gate already mentioned. This
Okay.
is the final summary. 48-year male presented with insidious onset, gradually progressive to recurrent unprovoked falls since 1.5 year, and slowness of activities of daily living since 1 year, which is symmetrical and with stiffness of both lower limbs. Dysarthria since 8 months and behavioral memory disturbances since 4 months. On examination, positive findings of uh, impaired trail B test with probable callosal apraxia and with vertical up gaze impairment predominantly, vertical down gaze impairment predominantly with slow vertical saccades, axial rigidity predominant than appendicular rigidity with grade 1 bradykinesia and a pull test grade 2 with the dystonia of the left upper limb and lower limb with probable arm levitation. So diagnosis, a typical Parkinsonism with recurrent falls with mild supranuclear vertical gaze palsy and with the execution deficits. So localization, pedunculopontine nucleus, basal ganglions and connections, DLPFC and probable orbitofrontal cortex I kept now. So here coming to this level of certainty from the this level of certainty, my patient is having this slow velocity of the vertical saccades and pull test is more than 2 steps backward on the pull test and this A1, A2, A3 cannot be considered. Why? Because it is not, patient is not akinetic rigid, but predominantly axial rigidity is more. And whether cognitive dysfunction, whether to consider it is a C2 in view of this trial A test, trial B test is impaired, and whether to consider is corticobacillar syndrome because this dystonia of the both the lower limbs, dystonia of left up lower limb as well as upper limb it is there, but there is no myoclonus that questionable that callosal apraxia is there. So coming to this C2, in whether to classify this patient into C2, there should be at least 3 of the following features. My patient is having dysexecutive syndrome in form of impaired trial B test and reduced phonemic verbal fluency. And this disinhibition perseveration, only this, there is no socially
He's
inappropriate.
having disinhibition. Huh?
No, disinhibition, no, ma'am. Inappropriate behaviors are not there. Actually, that speech, sometime he repeated, repetition of words is there, but those are not every time. So I kept some palilalia, thought of palilalia, but that is not there. In case of CBS C3, at least one sign in the following should be there. The patient is having callosal apraxia, but alien limb is not there. More than simple levitation should be there, and movement disorders, rigidity is there. So according to this, it can be considered as C3 only. So according to the degree of diagnostic certainty and this level of certainty, it can be considered as O2 plus P3, PSP with RS, or else like the patient is having O2 with C3. So PSP with predominant CBS. So it is a possible PSP with either it can be fitting into in view of predominant postural instability and down gaze palsy. Either it can be PSP with RS, other or else it can be with PSP with CBS. We should exclude the other causes of PSP mimics. So,
So which one you will put as the first possibility?
so here I will keep with this dystonia and this thing is there.
One thing we will not forget the hard features of falls. That is his hardest symptom. No.
Yes, yes, ma'am.
So he started with falls and he is having eye signs. He is having axial rigidity. All this will go with the PSP. So falls, eye signs and axial. The little unusual or the lack of pseudobulbar features, but he is having apraxia and some tendency for levitation and asymmetry. So asymmetry in the left upper limb with apraxic component. So my diagnosis will be PSP CBD overlap syndrome.
Okay.
That becomes the first possibility for me because I will not negate that falls at all, hard features. And of course, whether it is a imitation of a reversible condition with a degenerative disease, I will definitely like to rule out. This phenotype is that of a PSP CBS overlap. Is it having a reversible cause? I will definitely look for.
Yes.
So you have the investigations done, huh?
Investigations, yes, ma'am. Normal, almost like CSF was also done. It is also normal. Anti-TPO is negative. VDRL is negative. TSH previously, TSH is 50. Now it is 12.1, and rest everything is normal. MRI was done, which showed this predominant midbrain atrophy is there, and also here there is atrophy at the midbrain compared with the spons. So this
Morning glory like feature is there.
morning
in the-
glory is also there, and this hummingbird is not that much significant, but morning glory is there.
Morning glory is very much visible, and cerebellar atrophy is there. Cerebellar folia. In this picture, you can see the morning glory very clearly, and some prominence of the cerebellar folia. So predominantly, it is coming under PSP phenotype with some overlap features of CBD. That is what here also you feel so after radiology also.
Yes, yes.
So what are all the things you can treat in this patient? How are you going to treat him? It's a very young person, no?
Yes, ma'am. So in case of usually,
How are you going to help him to prevent falls? Because you said he had head injury,
yes,
fractures, injury to leg, so many things you told, no?
yes, ma'am.
So what methods you will adopt? Pharmacotherapy, non-pharmacotherapy?
Usually, this patient will not respond, this falls will not respond to this pharmacotherapy because it is not due to this basal ganglia pathology, it is due to this pedunculopontine nucleus pathology.
Norepinephrine. The neurotransmitter
Norepinephrine.
involved is not dopamine, norepinephrine.
Norepinephrine.
So
So,
we,
gait
so
and
they
balance
generally they do
training.
not respond to treatment. So you have to use non-pharmacological. Some mechanism helpful to solpidum. It is said that it helps, but I have not seen it help him. Literature says that solpidum, small doses can be used by some mechanism on the long loop reflexes. By working on the long loop reflexes, it is supposed to reduce the number of falls, but actually I have not done a study or anything. Unless you categorize controlled clinical study with the falls before and after, then only you will know. That we are not done, but solpidum is supposed to be useful. Otherwise, dopaminergic drugs do not help these patients. So you have to use non-pharmacological methods. Usually we advise assisted walking because fall prevention is very important. And you tell them to put some holding rails in the places where the patient walks, in the toilet or in your house itself. You have to fit the side rail so that when he loses the balance, he can quickly hold on and does not walk in dangerous places alone, and assisted walking. So important thing we understand that fall prevention is non-pharmacological for this patient. By giving an assisted walking system as well as environmental manipulation. Then the extrapyramidal component might respond to levodopa. Dystonia party, you can use some dopa agonist. Cognition party, subcortical, no? It's not cortical, so generally we use memantine. Cholinesterase inhibitors are not very useful. So autoimmune panel and all came, huh?
Autoimmune panel, no ma'am, autoimmune panel was sent actually. It was report is pending.
It is a MRI looks like degenerative.
Yes, ma'am. MRI.
What you will find in the MRI if it is autoimmune? Or not the typical features? Patient will have a lot of physiological dysfunction, functional dysfunction, but structural loss comes very late. The classical autoimmune, you will say limbic areas getting hyperintense signal changes, or it can be a normal also.
Yes, ma'am.
But atrophy is you find hyperintense signals in the cingulum and the singular limbic structures, medial temporal and all those things. But atrophy, unlike degenerative disease, is very late. So preserved volume, but signal changes, or even normal brain. So autoimmune, you find a normal brain, radiologically, it's not normal, but radiologically normal, or signal changes in the limbic area, but atrophy comes very, very late. Atrophy is not early. Whereas in this patient, only 1.5 years, so much of atrophy is there. So it's very likely that the autoimmune panel will be negative.
Negative.
Signal changes come, but volume change is very late, end stage disease. So
Autoimmune things which resemble this PSP are mostly the Siglon 5 and this anti-DPPX, but clinically, the Siglon 5, the patient is not having this predominant sleep disturbances and bulbar disturbances. Clinically also, it is not only the history-wise, it is going towards autoimmune, ma'am, but Siglon 5, which can mimic this PSP like this vertical.
clinically, we cannot say it is fitting into autoimmune.
Yes.
The other feature, clinically, what will be the feature in autoimmune? Because he's a young man.
Yes.
He's a young man, and there is autoimmune syndromes and paraneoplastic syndrome can mimic anything. So that way only we are applying that possibility. Otherwise, it is not typical. Clinically, autoimmune syndromes are very much suspected when they are much more rapid, and encephalopathy is a feature. Delirium, encephalopathy, no? That is the feature. None of those things are there in this patient. So clinical picture only on point, because he's a young man and you don't want to miss out on anything that might help him. That's all. Otherwise, neither the clinical picture nor radiological picture is typical of autoimmune. Only point is young age. You don't want to miss out a treatable condition. So autoimmune conditions are encephalopathies. So they present with drowsiness, delirium, and much more rapid progression. And radiologically, limbic structures can show signal changes or can be normal, and atrophy comes very late. So these are the points for autoimmune. Or none of those features are there. Only point is young, very young. So we don't want to miss out. That's why. Otherwise, it looked like degenerative. Good presentation, no? You have presented well. So I will tell him that you will fall prevention is a must. Otherwise, he will become very miserable with multiple fractures and head injuries. It's a very must. So they have to design their environment and help the patient. Second, the only useful drug will be anti-Parkinson drug for his axial rigidity, striatal toe. The dystonia part dopa agonist may be useful. And cognitive impairment, you have to do cognitive exercises. Young man, so you should not go demanded. It's only 10th standard. He may not be in the habit of doing cognitive exercises. Home-based cognitive exercises like letter cancellation, grind sorting, he can easily do. He should not think he is sick and sit in the corner. Read the newspaper and do a discussion or the brainstorming with his friends in the neighbors. So small things which he should do, and short-term fixed goals we tell. You see, short-term fixed goals means in the next 1 week, I will study one slogan. And it should involve all 3 processes: registration, retention, recall. And you can have some reminiscence therapy. So people say reality orientation, reminiscence, cognitive enhancement, and short-term fixed goals. So reality orientation is orient about the day, date, time, neighbors' names, you reorient every day. Things, so you are oriented and who is the politics, what is all those things happening in the environment, what is special for Yahadasi or something like that. All those reality orientation for that particular day, he should do every day. It is said that he should write it in a blackboard. Today is this day, this month, this year. Today special is this one. No, these are my close friends, relatives whom I met today. What I took today, all those things are reality orientation. Reminiscence is conversation may be poor for various reasons. His speech is monotonous. He may be depressed, no, and he may not want to reveal his disease itself, and he may not understand recent things. So we call reminiscence therapy. That is to encourage a conversation. You get his childhood friends. So he will remember his school days. Old memories will be good. So he will remember his teachers. So let them talk and joke so that some kind of socialization takes place. So that is reminiscence therapy, reality orientation reminiscence. Cognitive enhancements is the activities. You can start with letter cancellation, grind sorting, do some crossword puzzles, learn some slogas, try to mug up some phone numbers, no? Work on children's workbook. All this is cognitive enhancement. Highly qualified therapy techniques are there done by psychologists, computer-based or non-computer-based, but these things anybody can do, but it should be done in a everyday basis. And the goal should be fixed for short term. And if he is depressed, you can give some mood stabilizers and encourage him counseling. It's very sad. You should not get these diseases. All these words are for discussion, but in real life, the utility is much less. Patients go into irreversible damage over time. Anyway, good, ma. You presented well.
Thank
Any
you.
doubt you want to ask, you can ask. Thank you. Next
you.
week, we have a CME at Alleppey Medical College. Next Saturday, Sunday. So I'm
Okay.
going there.
Okay.
Sometime, if you find time, you can inform.
Okay.
You can take another class in after next week. Yes, I am somewhat slightly busy this week. So next week, I am in the CME program. So after that, one extra class in between, I can definitely take. If you feel so, you can inform me. Okay. Thank
Okay.
you.
Thank you.